Well, hello again. Here we are doing our next lecture. This is Module 6 for my course. And this lecture is going to include part 1 is Chapter 17 and 18, Newborn Transition from Fetal to Extrauterine Life and Nursing Care of the Newborn. And then I have a separate lecture, part 2, that's going to go a little more in depth into the disease processes that we see in NICU, so more of a critical care type portion. And I just want to point out a little bit about this picture very quickly. This is one of the reasons I use this picture. And I know it's kind of faded because it's got the blue tint to it. But you see all this skin discoloration. This is what we call mottling. Mottling is something that happens in newborns as they are, I believe it's when they're trying to dilate their vessels. So this is a sign of either being cold or a sign of one of the early signs of sepsis. Most likely, this baby is laying out here naked for this picture. So I'm thinking that this baby is probably cold, but I just wanted to point that out because it's a good example of it. Okay, let's get started. So this baby is born, delivered. We need to put this baby right skin to mom. We know that. One of the big trends that we've seen in the past few years, based on evidence, when we know better, we do better, is not clamping that cord right away, what's called delayed cord clamping. So we remember the placenta is giving everything to that baby, to the fetus, and then once the baby comes out, a lot of physiological changes have to happen in a pretty short period of time. And so by not clamping that cord, it's kind of that in between intrauterine life and extrauterine life. And so the placenta is still functioning as long as the placenta is intact inside the uterus. And so it gives that baby a little bit of what we call transition time. And there's a lot of good benefits to it. We a good portion of blood flow. There's still oxygenated blood coming that way until the baby can circulate through its own lungs. So delayed cord clamping is definitely evidence-based. Best place for this baby to go is skin to skin, and that means skin touching skin, not on top of the gown, not on top of a blanket. We want that skin touching skin, and there's actually a lot of benefits to this as well. It starts to regulate the baby's temperature. If on that note, if mom is cold, baby will be cold. If mom is hot, baby will get hot. So it definitely starts to regulate the temperature based on touch, and it also will start to regulate breathing, blood pressure, heart rate, blood sugar, does all kinds of amazing things. So skin to skin immediately. So at this moment of birth, the reason I'm showing this picture is this baby has to take a deep breath, push all the fluid that's in the lungs out of the lungs, open up those alveoli, start that gas exchange, and immediately start circulating blood through the lungs. And then once we clamp and cut this cord, the liver is going to start functioning at the extrauterine level. So a lot of things happen in that very first few minutes. These are all the different anatomic changes that happen. And if you're following along using the guided notes, you want to take a little look at this. The cardiovascular system, the big changes that we see is it's going to change from placental to pulmonary gas exchange. There are physical forces that allow that to happen. And inside the heart, I think I have a picture coming up of that. Inside the fetal heart, and we've talked about this before, a long time ago, many modules ago, we have several areas, the ductus arteriosus and the foramen ovale, that are open in the fetus but need to close in the newborn. And so those sometimes can take a little bit of time. And this is a description from your book of how that actually happens. But when this is happening, sometimes over a period of 24, 48 hours or so, we might hear some murmurs, some heart murmurs when we're listening to it because those areas have not completely closed. And so it's not uncommon to hear some whooshing sounds when you're listening to that heart rate. We obviously need this to function pretty quickly because this fetus or newborn doesn't have a backup anymore. And that's one of the things that we're going to be on the lookout for as a newborn nurse. So here are some ranges. Again, with ranges, every resource you have is going to have just slightly different ranges, but I just wanted you to have a baseline of what we're thinking about. Pay special attention here to your white blood cells. It is not uncommon to see higher white blood cells in that newborn because they've gone through this whole process of labor and birth. And so we are not surprised to see them up 27, 28, 29, 30,000 even. And in any other adult, you would start thinking infection at that rate. So the newborn levels are going to be very different than what we see. There are other early signs, early cues of newborn infection, and we'll be discussing those. So here's an aha moment, respiratory system adaptations. These alveoli, those little air-filled sacs in our lungs, they are functioning very well with the term newborn. They're available to move up and down and exchange that gas very efficiently. The premature newborn doesn't have that ability. And part of that reason is because they don't have enough surfactant. So surfactant is this soapy substance that prevents alveolar collapse. Okay, so if we have a baby that is being born premature, then we are going to be on the lookout for respiratory distress because of this role of surfactant, and they're not having not having as much surfactant. Now, we give a medication. This would be a good time to look at your notes, look at your medication notes. We give a medication to mothers if we anticipate the baby is going to be born early. And that is a steroid. And the steroid increases surfactant in the newborn. Now, there are some side effects that come along with that steroid to the mom, high blood glucose, and a potential of immunosuppression, which she already is immunosuppressed. So if the reason that she is in preterm labor is from infection, we've just fed it with high blood sugar and decreased her immune system. So I digress. The role of surfactant, very important. We don't see it as much in premature babies, and you definitely want to be on the lookout for signs of respiratory distress. And that would be respirations that are outside of this normal range. 30 to 60 is what we are looking for. They are irregular already, shallow, and unlabored. Now, if we see labored breathing and increased respiratory rate, then we are concerned that this baby is moving into respiratory distress. Our newborns are predisposed to heat loss, and on the screen here is a list of reasons. Part of the neurological system is they don't really have the ability to shiver. They have very thin skin with those blood vessels close to the surface. They can't voluntarily move their muscles. That's involuntary movement for most. And they have lack of subcutaneous fat. They have a specific ability to utilize brown fat, but they use that up very quickly. This is a NCLEX question. They really like to know the types of heat exchange for these newborns. So you're going to take a look at this: conduction, convection, evaporation, radiation. And here is a picture of all of those. Conduction being laying them on a cool or warm surface. They can exchange heat that way. Convection is like a breeze blowing through the room. Evaporation is being wet and them just evaporating, which is why we keep them covered or keep them skin to skin. And radiation is going to come from an outside source, so either cold or hot through the walls or window or that sort of thing. So knowing the different types of heat exchange is important. We take a baby's temperature axillary, and when we're doing that, we want to use a digital thermometer, and we want to make sure that this is not poking out the back of the baby's arm. A lot of times this will actually turn and go in this way, and you have to hold the baby's arm down because they won't help you, number one. And number two, if it's not tightly in there, you're not going to get a good reading. If this baby is cold, like this baby, 36.1, definitely cold. You're going to look at your reference ranges again to make sure you know what is a normal temperature. We want to do something to heat this baby up. The first action would be to put this baby skin to skin with one of the parents. And then if that's not available, or if the baby's significantly cold and we're worried about having to do some other interventions, we might put them on a radiant heat lamp, a radiant warmer. And so there's a heat that comes out of here, and it can be attached to a probe that tells the heat lamp heat up because the baby's cold, or cool down because the baby is warm. We never leave a baby on a warmer unattended without a probe attached. That's a safety tool. And we don't want them to be cold stressed because their other systems won't work, won't function appropriately. And so we want them in what we call a neutral thermal environment. The liver, as I mentioned before, is not really functioning until, I mean, there's a slight function to it, but the placenta is acting as the liver until we cut and clamp that cord. And so it's immature to begin with. And a premature baby, it's even more immature. Its purpose is iron storage. They have storage there for about 3-ish months. It's carbohydrate metabolism, and the breast milk and formula that they take is mostly carbohydrate. And it's there to conjugate bilirubin. But because it's on the immature side, sometimes it takes some days to get up to par. And we're going to be discussing what that means for this newborn here in just a few slides. Gastrointestinal system, the stomach is very small. It is considerably less than anatomic capacity. There is a development of a mucosal barrier, which builds immunity and starts to keep harmful bacteria from entering through the gut. And we know that breast milk, or the very first breast milk, we call it colostrum, is one of the things it does is it coats and helps to build that mucosal barrier to start building that immune system. And we think that's why there's some differences in formula-fed and breast milk-fed babies. To gain weight, the newborn requires about 108 calories per kilogram per day from birth to about 6 months of age. So when it's by kilogram, then as the baby grows, the intake increases. So here's just an example of our newborn stomach size. On that very first day, it's only about the size of a cherry. So there's no reason, which is about a teaspoon. There's no reason for us to be concerned about volume in those first few days. We obviously want to get enough, and we'll talk about how we know there's enough, but we don't have to overfeed them with large volumes. And sometimes, we've been taught if we see a bottle that has 4 ounces in it, that must be what a baby needs, 4 ounces, but it's not. Most of the time, the bottles that are in the hospital, the pre-made bottles, have 2 ounces in them, and that's far more than what a baby needs per feeding. The characteristics of the newborn stool are different, and we need to be paying close attention to them. And this is an important teaching topic for our new moms before they go home. So that first stool is meconium, and that's just a thick, tarry, sticky substance. And then it's going to move to transitional stool, and then it will move to milk stool based on what they are being fed. So that transitional stool is an important key element that we need to be paying attention to. Happens about the 3rd day, and that coincides with when that larger milk volume starts to happen. And it's one of the ways give us a clue if the baby's getting what they need. They're getting adequate amounts of feeding. Here are some pictures of that stool. This is meconium, and then we have that transitional stool, and then it should be yellow. So if we're doing any sort of follow-up phone calls or talking to moms, checking in on them after they've gone home, our transitional stool needs to be there by day 3 or 4. We shouldn't still be seeing meconium on that day. That tells us there haven't been enough stools, which may be because there has not been enough intake. And then we want to have a minimum of 6 to 8 wet diapers in 24 hours. So 6 to 8 wet diapers over a 24-hour period by day 6. That's another way that we know that they're getting adequate intake. So that's one of the key factors that we're telling parents to look for, as well as asking if we're having any contact with them. Their renal system has limited ability to concentrate urine, so they cannot be without. They have this low glomerular filtration rate, and limited excretion affects their ability to excrete water, salt, and medication. So the newborn is going to have very specific ranges for fluid volume, as well as any electrolyte replacement. This is why newborns have to be cared for in a special nursery, NICU, neonatal intensive care unit, and not just on a regular pediatric floor. And then their immunity. Their immune system comes from their mother. So we call this acquired immunity, and it's primarily dependent on 3 immunoglobulins that sometimes you'll see it. NCLEX likes to ask you which one. It's IgG that crosses the placenta, and that's directly related to what the mother's immunity was. So this is why we suggest those different vaccines in the 3rd trimester, because even if the mom has immunity to it for herself, she's building immunity again, and that is passed to the newborn. The integumentary system has lots of changes going on because it's going from a wet environment to a dry environment. So babies often are covered in what we call, this is called vernix, and there's actually a lot of reason for this vernix to be there. It keeps them waterproof on the inside. It helps their bodies not to become all wrinkly, and it is a barrier for the skin. It's also very sticky, and so when we put a baby skin to skin with their parents, then that allows the bacteria from the skin to adhere to this baby and start exposing them to some of those bacteria in their environment, so they can start to build their immune system. It's really amazing, everything that it does. It protects against physical trauma. So in the old days, we used to just scrub all of this off, but now we know that it's there for a reason, and removing it right away is not necessary. Their neurological system is going to develop what we call the cephalocaudal pattern, meaning it starts at the head and moves down from that area, and then proximal to the distal. So this is how they're going to develop over the next few months. They have acute senses of hearing, smell, and taste, and we are looking for specific reflexes as an indication of how neurologically developed they are at that point and what their function is. There are specific behavioral patterns in the newborn. In that first 30 minutes to 2 hours, they have this initial period of reactivity. This is a great time for them to have that first feeding. They're usually alert, they're moving around, they're recovering from delivery, they're being exposed to all the new sights and sounds and feelings that they didn't have when they were in utero. And then they're going to have a period of decreased responsiveness, and they might sleep for several hours at this point. This is a great time to encourage the parents to try to catch up on their sleep if they can. And then about 2 to 8 hours after birth, they're going to have another period of reactivity. So this is that period of time, that decreased responsiveness, we call it that sleepy period after birth that we expect, which is why it's so important to get this baby fed in this early period of time. And we really recommend not doing any interventions until the baby's had the first feeding, because we don't want them to get distracted. And this is another one of those when we know better, we do better events. We used to do all sorts of things to these babies right away, and now we know that they need to feed first, and then we can do all of our measurements and newborn medications and all the things that have to be done. Babies have the ability to respond to stimuli, and they can have the ability to be overstimulated by too much stimuli. And we have to kind of look at the cues of this baby to see how well they're managing that. They also have the ability to self-quiet and console themselves if we let them. They enjoy cuddling and snuggling. They have social behaviors. So newborns are actually very intelligent and socially adaptable and aware. We kind of think of them as just the newborn over in the corner, but they actually are interacting with their world quite distinctly. Okay, so now we're going to move on to chapter 18 and think about the management of the newborn. We have all these changes that are happening, as I just mentioned, during that transition time. And we call that transition time somewhere the first 2-ish hours or so. Some places will stretch that out to the first 4 hours, but they need to be watched closely during this transition time. At the same time that mom, who just had a baby, needs to be watched closely. So our initial assessments, we're going to be giving an APGAR score. We'll talk about that in a minute. Eventually, we're going to get to length and weight and other measurements. Vital signs need to be taken pretty quickly and on a regular basis, because those are our early cues that something might not be okay. We are going to be doing a gestational age assessment, and really it's a gestational maturity assessment. We'll talk about that. And these are the things that we're looking at to determine gestational maturity. So our APGAR is just a quick assessment of how the baby is transitioning from intrauterine life to extrauterine life. And so it doesn't mean anything other than it's a way of communication. So when we're looking at an APGAR score, we're actually measuring these 5 components of the APGAR, of the baby's behavior, and giving them a score of either 0, 1, or 2. So the lowest score you can have altogether is a 0, and the highest score you can have is a 10. It's pretty rare for the first score, which is at 1 minute of life. First one is at 1 minute. The second one is at 5 minutes. And then if that 5-minute score doesn't meet a certain threshold, we will keep doing the score. And again, it's a way of letting us know how well the baby was transitioning. So for an example, you can see how the scoring systems are rated here. If I have a score of 4, that means that I am actually helping this baby with some sort of resuscitation measures to breathe and or heart rate at that point. And so if I'm giving report and I say, yes, my baby had an APGAR of 4 and then 7, I automatically know this baby had a little bit of a tough time transitioning and may have used up all of its sugar and all of its resources. And so I, as the postpartum nurse, now need to be watching very closely to make sure this baby doesn't have problems down the road. So it's a way of communication. This is a baby that has an APGAR score of about, I'd say 8 or 9. And you can see it's grimacing, which means it's crying. It's pink almost everywhere except for the hands. It is has a heart rate, so it's pink, so we know it has a heart rate. This baby, on the other hand, you can tell does not have those things, and so this baby is going to need some help. This is taken from the neonatal resuscitation book, so this baby is going to get some assistance. So our measurements, again, these don't have to happen right away. We're going to put them on a scale and we'll measure them in pounds and in kilograms. And it'll most likely be documented both ways. And then we're going to measure the length. And the best way to do that is to have this baby on a chucks and mark the top of the head here on the chucks. and then stretch out 1 foot and make a mark and then measure between those 2 marks. It's really difficult to try to wrap this measuring device around a baby. And we're going to be measuring weight and length specifically because we want to be able to then graph it to see where this baby falls. Are they small for gestational age, average for gestational age, or large for gestational age? Eventually, we're going to do these measurements as well. We'll do the chest measurement. As long as you do it the same way every time, it's typically done right at the nipple line. And then we're going to be measuring the head circumference, and it's done right at the crown of the head. And this may change over the next few days because that molding may have happened and it might change the shape of that head as it goes back to its predisposed, its previous non-molded level. When we look at gestational age, we are looking at preterm is anything less than 37 weeks. And then we have term, anything 38 to 42 weeks. So again, these ranges might be a little different. Some places will say term is 37 weeks to 42 weeks. Post-term is anything technically after 42 weeks, and post-mature is, this actually, post-term would be anything after the 42nd week of gestation. And then there are signs, post-mature is with signs of placental aging. So a long time ago, when we talked about how we date pregnancies, we are not exact. We don't know exactly how many weeks these babies are inside there, and we don't have a good way of knowing. We know ranges. So if they're premature, we know we're going to be looking for things like respiratory distress and not being able to maintain their temperature well and poor feeding potentially. If they're post-mature, we might see signs of there might have been meconium in the delivery process. So we're also looking for respiratory distress. So having an idea of what the gestational age helps us kind of fit our baby into categories, but each baby is unique and we need to be looking at our assessment criteria for all of these babies. Here are some pictures of some different gestational age babies. You can see this baby is premature. They have that classic frog-like posture because the musculature has just not been developed. This baby is probably small for gestational age, and this baby is most likely large for gestational age. You can see it's completely filled out. If you can see the creases on the feet, they're probably all the way down. So just 3 different looks at the different babies. Again, this Ballard scores is one of the scoring systems we can use to look at gestational maturity. You don't have to learn how to do this. I just want you to know what we're talking about when we're talking about a Ballard score. This is one of the ways that they will kind of predict where that baby is for mature-wise. And then that just helps us predict the behavior, like feeding and maintaining temperature and respiratory. I think I've mentioned this in other lectures, but a quick little way of determining gestational age or gestational maturity is to look at the bottom of their feet. This baby at 28 weeks has no creases, essentially. It's a very smooth, thin skin. This baby at term has creases all the way down the foot. So that's just a quick way of looking at gestational maturity. And if this baby were to deliver somewhere outside of a unit and you don't have any idea how old it is, you can take a look there and get an estimate. Excuse me. And so then we look at size for gestational age. Our babies can be small for gestational age, so it might be term, but on the smaller side because of certain disease processes that mom might have experienced. Maybe there was a knot in the cord. Maybe she had hypertension. Maybe there was something else. Maybe she had infection during pregnancy, and that can lead to a small for gestational age. And then our large for gestational age may be an infant of a diabetic mother. And that shows that this baby had large doses of high blood sugar, exposure to high blood sugar. So these are also categories that we need to pay attention to when we're caring for our newborns. And so here is a small for gestational age baby next to a large for gestational age baby. These babies are actually the same age. And then looking at our temperatures, again, these ranges come straight out of your book. They may be slightly different than your pocket guide. I might have used a different reference, but or maybe the hospital policy. We always are going to go with what is hospital policy. So for instance, I know in our local hospitals, we want to see 120 to 160, but most textbooks still say 110 to 160. And so understanding these reference ranges are essential to your care of a newborn because this is what you're going to compare each newborn to and decide if you need to investigate further for potential problems. We cannot wait for a newborn to throw up all the red flags and say, I need help, because they're very difficult to help at that point. So an interesting fact about newborns is that sometimes if they are starting to brew an infection, your first sign might be a low temperature, not a high temperature. They don't have the ability to create enough energy to make a high temperature in those first few days. And so we are looking for low temperatures. And you want to write this down. Low temperatures can be a sign of early infection or a sign of hypoglycemia in a newborn. Respiratory rate, high respiratory rate would be a sign of early infection. Again, that's another one of our first cues, our early cues, and or moving into respiratory distress. So these are our early warning signs for our newborn. Other assessments you're going to be looking for. Okay, so our other newborn assessments, things we're going to be looking for is nasal flaring. Nasal flaring is seeing that those little nares breathing in and out with the breaths, and chest retractions, seeing the muscles of the chest compressing in and out with each breath tells us that the babies are really working hard to breathe. Grunting when they make a sound with each exhalation. Central cyanosis, flaccid body posture. They should be nice and flexed. If you hear abnormal breath sounds or abnormal heart rates, those are all things that we're looking for. Now, a note here about the central cyanosis. That is around the lips, mouth, and chest. We aren't as concerned with acrocyanosis, which is blue hands and blue feet. That's one of the symptoms of that transition from intrauterine life to extrauterine life. And it only lasts about 24, 48 hours at the maximum. We shouldn't see any cyanosis after that point, but we're specifically looking early on for central cyanosis. Parents can be very concerned about acrocyanosis, and we need to reassure them that that's normal, and that's a great time to educate about central. So again, same baby, and then this baby is looking pretty good, but you can see that the hands are still blue and the feet are still very pale. So this baby has acrocyanosis, but I would say if I were going to give this baby an APGAR score, it's a 9. Here's a picture of those retractions. You can see they catch it. They're breathing in, and you can see all their muscular movements. Same here for this baby. So those are retractions. So our immediate newborn period, obviously you want to think airway, breathing, circulation, and we want to make sure that we are maintaining airway patency. Some of the education that we need to give the parents is having that baby up next to them really close. We want to make sure that they have airway clearance so that they can keep breathing. And then at some point, we need to properly identify them. That is our role. Make sure that we put our bands on those babies if they're born in a hospital facility. Maintaining thermoregulation, again, the most appropriate thing to do first is put baby skin to skin, and then we can move on to other means if we need to. And then we're going to be giving some prescribed medications, and you want to take a look at your drug guide in 18.1 at the different medications and what they are used for. They're also listed in the medication video if you need to take a look at that. So these are the challenges that are faced by a newborn that we're always on the lookout for and trying to avoid. Looking at those system-wide changes, we know that those are big challenges in the first few hours. We don't want to cold stress them. And then bilirubin conjugation and jaundice. We're going to talk more about that as we continue on through the lecture. But these are challenges that are faced by pretty much every newborn that we are on the lookout for. So we want to know about prenatal history, obviously any infections, what the delivery was like, if there were any issues during prenatal care. And then we're going to do a physical exam. And this is after the baby's had its first feeding, we're going to be doing this physical exam. And we're going to be looking for variances outside of the normal range. Our job at that point is to report those to the provider. It may be a midwife caring for this baby because they care for newborns up to 28 days. It may be a family practice nurse that is caring for this baby. It may be a pediatrician. It may be a family practice physician. We are going to be looking for variances in the face, neck, abdomen, genitalia, extremities, and back, and we're going to be looking at the neurological status. So there are lots of skin variations in newborns. All of the things listed on this page are skin variations that don't necessarily have we don't have to do anything about them. You just need to be aware of them so that you recognize what's normal so you can recognize what's not normal. So looking very quickly, here's that vernix again that I talked about. These are called Mongolian spots. They typically are on the back, maybe lower legs. They look like bruises, but they're just a skin variant. You see them most often in darker skinned genetic history. These are called milia. These are just little white spots that are clogged duct, a clogged pore. We do not need to pop them. There's nothing abnormal about them. They will resolve on their own. This is what we call a stork bite. This is on the back of the neck, and it is just another skin variation. Sometimes they can be on the forehead, and they can become very reddened when the baby is crying, but it's nothing to be worried about. This is a port wine stain. This is another skin variation that babies can be born with. Sometimes they do get darker. There are treatments that can happen later on if they're very distressing to the child, but it's just what makes them unique. This is called the strawberry hemangioma. And again, it's just a variation that needs to be pointed out to the provider or noted on your assessment. And this is what we call newborn, let me go back here. That is erythema toxicum. And this is a pretty severe case of it, but it's just what we call a normal newborn rash. This normal newborn rash is a response from fetal life to extrauterine life. Some theories are that it's a response to the hormones of the baby. There's nothing wrong here. This is a normal expectation. And even though it looks really intense, we need to educate early on that there's no reason to come back to an urgent care or an ER and expose this baby for a normal newborn rash. And the way we know that a baby is doing well is how's the temperature? Is it maintaining its temperature? Is it feeding well? And do all of its breathing and heart rate, is that in normal range? And is elimination happening? So those are the signs that we need to be looking for our newborns. This is normal newborn rash. Okay, there are some variations in head shape and size. We're going to talk about the ones that are listed on the screen here. So this is what we call molding. Remember, these bones are not fused and they have the ability to slide on top of each other. And that's what's happened here. There's probably some swelling, what we call caput, just fluid underneath this tissue that is making this so pronounced. This will get better in a couple of days. When it gets outside of the range of normal is when we see something called a hematoma, cephalohematoma. This is typically much lower and closer to the brain. And the way we know that is it does not cross that suture line. Remember, we have those sutures between the bones. And so if it does not cross that suture line, we know it's lower. And so a cephalohematoma, we need to be watching for other signs of brain um, uh, involvement. So high-pitched cry, rigid, seizure activity. Those would be things that we would be concerned about if we have some bleeding in this deeper area, cephalohematoma, versus caput, which does cross the suture line, and that is just edema, just fluid, and that should resolve. The other thing we need to be on the lookout for if we have bleeding underneath is now we have excess red blood cells, which is going to increase our incidence of jaundice. We'll talk about that. We want to look for macrocephaly versus microcephaly. So this is a hydrocephalus diagnosis where there is fluid built up that is causing the skull to swell. And so this is one of the reasons that we do that measurement, which is a measurement early on as a baseline. And then microcephaly is something that we see with certain infections, specifically Zika. You might see it with cytomegalovirus, some of those other infections that we've talked about. And then looking at those reflexes, the reflexes that we know are important and they're easy to see: blinking, sneezing, gagging, sucking, and grasping. If we see these reflexes, we know the baby is well developed. There are some other reflexes that are kind of obscure, like the stepping reflex. There's no reason for us to really test that. It doesn't really tell us anything. And then their eyes. Often their eyes are crossed. They don't have real good control over accommodation at that point. And so letting the parents know that this is going to develop the more they use those eyes and are looking at face, looking at this position where they're being held, then this will get better. But this is a normal variation and nothing to be concerned about. When we're looking at the ear, we want the edge of the ear, the outer pinna, top of the outer pinna, to be just about in line with the eye. And you can see this one is what we call a low set ear. And that is a variation that we definitely need to inform our provider about, because some of these are associated with other genetic conditions, genetic differences. And then if we see skin tags, again, this is something that needs to be reported and documented, because these can be associated with some genetic differences as well, specifically the kidneys. Other concerns that we see in the first days of life: transient tachypnea of the newborn. We'll talk about that. Hypoglycemia of the newborn, and then pathological versus physiological jaundice. So transient tachypnea means that it's fast breathing that comes and goes. And that can be a normal variation in those first few days. We just want to make sure that it resolves on its own. And sometimes these babies have a little bit difficulty feeding when they're breathing so fast. You can't be breathing 70, 80, 90 times a minute and be able to suck efficiently. So this is something that will be the treatment of it will be determined by each facility. Some facilities are more conservative than others, but it's something that we need to be on the lookout for. And then hypoglycemia, we need to be on the lookout for babies that are not feeding well, they have poor feeding, or that were born to mothers with diabetes. We are on the lookout for hypoglycemia, or a baby that had a really difficult delivery and used up all of its energy and had a resuscitation might be at risk for hypoglycemia in those first few hours. So we need to be on the lookout for that. And then pathological jaundice. So jaundice is the yellowing of the skin, the outward appearance of the excess bilirubin that is in the body. So remember, the liver is going to conjugate that bilirubin, but in the first few days, it's just a little on the immature side. It also gets overwhelmed by certain conditions that the mother and the baby might have. So pathological jaundice is when we have a high level of jaundice in the first 24 hours. And these are usually related to a diagnosis, a medical diagnosis, or a condition that something's going on. Physiological jaundice is actually an expected finding over the first few days. We just want to make sure we're not moving into that higher level because that can cause other conditions, and we'll talk about that in just a second. So our interventions for transient tachypnea provide oxygen if necessary, making sure that they have good oxygen exchange, ensuring warmth, and really observing them frequently, making sure that they're able to push that excess fluid out of the way and have a good oxygen exchange. Nursing interventions for physiological jaundice begins after 24 hours of age. Remember, pathological if it's before 24 hours. Know the difference between those two terms. And our intervention for this is really frequent feeding, because our physiological jaundice can be just not enough formula or breast milk coming in, not enough of an exchange to push everything out of the body. The number one way we get bilirubin out of the body is through stool. So if the baby's not feeding very well, or not feeding enough, or if there's just not quite enough colostrum in those first few days, then we might see not enough feeding jaundice, and that it can be remedied by increasing those feeds. If they get into a high risk zone, I'll talk more about how we measure that in a minute. If they get into a high risk zone, you might see some phototherapy recommended. That's kind of been the newest trend based on evidence, is getting them down into the lower risk zones before we send them home. We're going to be monitoring their hydration status. We're going to be monitoring their stools and their skin color. So now I say skin color cautiously, because visual inspection is a very poor indication of how jaundiced someone is. Obviously, if they're pumpkin orange, we know that their jaundice levels are high, but everyone has a little bit different skin tone. So we no longer use the description that's in your book of blanching the skin to, quote, test for jaundice. We no longer use that. We use other methods and tools, and we'll talk about it. So some of the things that are increased risk factors, these are going to increase your chance for that pathological jaundice, is increased red blood cell production. And that comes from babies that are born to mothers with maternal diabetes. That's one of the conditions that we will see an increased red blood cell production. And that's because that glucose actually lives on a blood cell. That's why when you're doing a test in an adult and you do a hemoglobin A1C, you're actually looking at the red blood cells, which live for 90-ish days or so. And that's how you can tell what the blood sugar's been for the last 3 months. Another condition that might lead to increased jaundice is an Rh or an ABO incompatibility. Remember that Rh negative mom or ABO blood type incompatibility, there might be antibodies involved, and that will increase the destruction of red blood cells, which, remember, have to be conjugated and broken down in the liver. Decreased liver function, so immaturity, oxytocin in labor increases the chance for jaundice. I don't know exactly how, but I know it's on the list of risk factors. Hyperthyroidism, extreme ecchymosis, which is bruising, will cause an increase in red blood cells, because that's what the bruise is, blood vessels or blood cells that need to be broken down. So we're on the lookout for jaundice if we have bruising, if we had a long induction with oxytocin, if we had a mom that has any type of diabetes, if that baby's immature. It increases our assessment. So this is called the Butani nomogram, and this is a way of knowing what risk zone our newborn is in. So when you're looking at the nomogram, you are looking at hours old across the bottom, and you can see, you can count your scale, it's by twos, 2, 4, 6, 8, 10, 12. So this is hours old versus the serum or the transcutaneous Billy number. So if we're using a transcutaneous Billy number, this is a machine that we can use on the skin that essentially blanches it, but gives us an actual number rather than just using our eyes to say, that's yellow, that's not yellow. So if we're using a transcutaneous number and we, let's just say that our baby's 24 hours old and we get a level of 9. So 24 hours old, and then I'm going to count up here. That's 5, 6, 7, 8, 9. I am clearly in the high risk zone, and that means that my jaundice is coming from a pathological reason, most likely, and that needs to be investigated, and it needs to be treated aggressively. And the reason is, for the next 72 hours, we expect that this jaundice level will rise and peak somewhere about here. So give yourself a couple of numbers and practice this. If that same baby is 36 hours old and is at a 9, you can see that we have brought ourselves down into a much lower risk zone. If that same baby is 60 hours old and at a 9, we are just now coming almost into the low risk zone. So what does this do? In the hospital, this allows us to predict where our baby is going to end up. We don't look at specific numbers like a lab value to determine if the baby is jaundice or not. We're looking, even though that's what your textbook says, we're actually looking at what risk zone they are in to determine what our interventions will be. So what we are concerned about is a condition called kernicterus. Kernicterus is when we have levels so high up here in the 20, 25 level. We have levels so high, we are concerned about brain damage because high bilirubin levels are toxic to the newborn brain, and they can cause a condition called kernicterus. A really great video that you should watch, it's on my playlist in the newborn section. It's called Prevent This. You can even just search Prevent This Jaundice, and it will come up with a 10-minute video that is well worth your time. This video shows you evidence-based practice over the last 10 years and how we went from not really assessing these babies with jaundice to completely changing the outlook for every baby that is at a potential risk of brain damage. And there's a lot of parents that are talking about it, and children. You can see what kernicterus looks like in children. So highly recommend this, Prevent This. It's an older video, but it's well worth your time. So we're worried about kernicterus. We're going to assess the risk zone to determine where this baby is before they go home. So that will determine our interventions for each risk zone. Again, bilirubin is the breakdown of red blood cells, and it needs to happen over the first few days. Our liver is immature, and sometimes we get a buildup that causes circulating bilirubin that hasn't been conjugated by the liver yet. Number one way that we get bilirubin out of the body is stool, stool, stool. Now, sometimes you'll hear pediatricians will say, put your baby in the sunlight, but there's some controversy about that. We don't want to take our babies directly out into the sunlight, and that's where that research was done. It was done in sub-Saharan Africa, where they have large amounts of sunlight. And if you put your baby in the window nowadays, we are actually blocking a lot of those UV rays. So it's not as effective as it was once thought to be. We now know get the bilirubin out through the stool, through increasing those feeds if necessary. And if we have to, we might use a Billy light in the hospital in a controlled setting to decrease some of that bilirubin, to break it down through the skin. So our nursing interventions for hypoglycemia, we are looking at our policy again in the hospital, but some of the things that we can do is breastfeeding. If the baby is not latching well to the breast, then we can hand express and feed baby another route. We'll talk more about that in a minute. If we don't have access to breast milk, we might formula feed if our blood glucose levels are low. And if it's urgent, we might use dextrose gel, or some places still start an IV and do some D10 to increase those blood glucose levels. So anything less than 45 is going to be our magic number for our purposes here today. It's going to be based on your policy, but anything less than 45 is considered hypoglycemic. There are several screening exams that we're going to use for the newborn. They're listed here on your screen: the newborn screen, the hearing screen, congenital heart screen, and that jaundice risk category using that Butani nomogram like we just mentioned. This newborn screen, sometimes referred to as the PKU test, that's an old term because that was one of the first things we tested for, was the phenylketonuria. They do still test for that, but they also test for about 70 other diseases and genetic conditions. And so it is taken by a heel stick, and there's actually 7 little circles that they use on the newest screen, 7, I think. When you're taking blood from a newborn, the practice is put your thumb against the heel of the newborn. And so your thumb would be right here in the center. And anywhere that your thumb is not is where you can actually use to do a newborn heel stick. And we don't want them to be screaming and crying when they do this because it kind of clamps the vessels down. So you want them to be in a nice, comfortable, possibly swaddled or even at the breast if they're breastfeeding. And that will help you get a good sample. These are sent off to the testing facility of the state. And then if there's any problems, they will contact the parent. And this is just a screening exam. This is not diagnostic. And this is the form, the state form that needs to be filled out. This one is specific to California. All of this information will be filled out by the facility, and the 6 circles now. And then again, this is important that we have good contact information because that's how they will be contacted. The newborn hearing screen program it's a screening tool to determine those early congenital hearing deficits. They actually place some electrodes on the baby's head, and then they have these little earphones that they make some clicking noises, and they record brain waves. Sometimes in the early newborn period, the ear canals can still be full of fluid and they don't hear them as well. So they might have to have a retest done. But this screening program helps us detect those that maybe won't be detected until much later, and they can start early intervention. And I think the statistic, let's see if I have it on the screen. No, I don't. I think the statistic is something really high, like 80% of our congenital hearing deficits they don't run in families, that they're just spontaneous appear. That might be kind of a high number, but it's 50 to 80%, something really high. So doing the hearing screen is a good thing. This is the congenital heart screening, and this is looking for those those early signs of desaturation in some of the congenital heart differences that we see. And so we're looking at preductal and postductal O2 sats at the same time, and we're comparing those differences. So we are doing this as close to discharge as possible. And we know that if this baby screens positive, meaning there's an issue, then we would want to do some further follow-up. The other condition that this has really started to detect is those early signs of desaturation that we see in neonatal sepsis. And so it's really a great little non-invasive, inexpensive test that they can do right before they go home to try to screen out some of those babies that are going to have difficulties. So the congenital heart defect screening is considered failed if at any point the oxygen saturation is less than 90%. And this is why we want to do it as close to discharge as possible, because the oxygen saturation right after delivery can be under 90%, and it can be a normal variant. If at any point the difference between the preductal and postductal is more than 3%, that is considered a failed screen. And if there's less than 90% in either of those on 3 separate occasions, separated by an hour each, then it's considered failed. So this needs to be done by either a respiratory therapist or an RN. LVNs can do these as well. And this is going to be documented in the medical record. These are the conditions that we are most familiar with, are congenital heart conditions. And not all of these are going to be detected in the congenital heart screen, but just so you can see some of the terms: tetralogy of Fallot, your ASDs and your VSDs, and your patent ductus arteriosus. That's when that little area of the fetal heart doesn't close all the way, so it remains patent. These are all conditions that can affect oxygenation in the newborn. And you're going to cover more of these in our program. You're going to cover more of this in your pediatrics courses. Early nutrition. So when we're looking at our fetus or our newborn, sorry, we are looking at early nutrition, and they don't need anything other than either breast milk or formula. They don't need excess water. They don't need any other calories in any other way. It needs to be just in the form of formula or breast milk. And that is going to be up to the parent, and we need to support the parent's choice, but it needs to be informed consent. And in order to do that, they have to know risk, benefit, and alternative of each, right? So they need to know the risks of formula feeding in order to make an informed choice about that using shared decision making. Again, this is the ventral position. This is the natural feeding position of a newborn. Looking at the volume size again, our babies have very small tummies in the beginning, 5 to 7 mLs, which is half a teaspoon to a teaspoon. And so they don't need a large amount of volume. By day 3, they're looking at a larger volume. By week 1 is when we start to see those ounces come into play. And by 1 month is when you start to see 2.5 to 5 ounces. Again, based on kilograms of weight and baby's behavior, personality. Some are wanting their tummies to feel fuller than others. And but we just need to be on the lookout, because if we're overfeeding this newborn, they're going to expect large volumes very quickly, and they might start vomiting it back up because they've been overfed. We want to look for our early feeding cues versus our late feeding cues. Our early cues are when they first start opening their mouth, turning their head, rooting. Our late feeding cues are crying and being very agitated. So if we can get to our babies early, they will have a longer, more satisfying feed than if we wait until they're late, because then they're just hangry and they don't want to learn something new, and they don't want to be patient waiting for the milk to come. When we are teaching about breastfeeding, these are all the things that we need to talk about to our parents before they go home, talking about the composition of milk and how amazing it is that it changes composition based on the gestational age of the baby, based on the time of day, based on what's going on with the mom. If she's been exposed to something, she's going to have antibodies that are in her breast milk before she even shows signs of illness. We also want to make sure she knows how to store and express that breast milk, especially in areas where they have things like natural disasters and they might not have access to alternative methods of feeding. We want to discuss the most common concerns: sore nipples, engorgement, mastitis, and provide any assistance with getting this baby latched if possible. Just a reminder what the physiology is: their baby must be at the breast, or the milk must be coming out of the breast in order to tell the body make milk. And we don't want to interrupt that process with any sort of alternative pacifier or feedings away from the breast if at all possible. Looking at this breast tissue, it is not the nipple that provides the milk. It's actually these sinuses right back here behind the areola. And so that's why the baby needs to put their mouth all the way on this section in order to massage those sinuses that initiates the response for the milk to come down from the mammary gland. If the baby is just on the nipple, we're not getting that message to the milk or to the breast, and they're not emptying that breast. They're not getting sending that message out to make more milk, because milk is not leaving the breast. Also will make you very sore. So again, here's a correct latch, baby on as much as possible. This is looking at the correct latch. Obviously, this is a exaggerated illustration of what the nipple looks like, but the baby actually uses the tongue to compress the nipple, which creates a siphon effect on those glands that I just mentioned. And we actually have a latch assessment to determine how well this newborn is latching. This is an important assessment that we can do before they leave the hospital to determine if they need excess help outside of the hospital. So do they need a referral to a lactation consultant based on their latch assessment? And just a quick note here about breast augmentation using implants. I get a lot of questions about that because I'm a lactation consultant as well. So here's a natural breast without any implants. You can still breastfeed with implants. A lot of it depends on where they were placed and how long ago they were placed. There are two types of breast implants. The first one goes above the muscle and they cut through right here to enter this implant into the breast. And so they're cutting through all of these tubules and the highways essentially of getting the milk out of the breast. And so depending on how long it's been, these can recannulize, but if it was very recent, they may not. So you may be making plenty of milk, but you just can't get it out of the breast. And so we're not getting the message to the brain to make more milk. The other one is behind the muscle. And the way they do that is they go in through the axilla, through the armpit, and they place it behind the muscle. And that the nerves that send that message up to the brain that says we've got milk being released from the breast are over in that area. And so sometimes you will see, again, enough milk being made initially, but the message just not being sent. So the key message here is it would be important for you to work with a lactation consultant if you've had a breast augmentation, if you are planning to breastfeed. Now, if you've had a breast reduction, you most likely will not be able to breastfeed solely, only because they cut through all these cannulas, move the nipple, and there's just too much damage to the breast tissue. There are other alternative methods that people can do if they've had a reduction, like using a supplemental nursing system, that sort of thing. But you would need to work with a consultant. Knowing how to get the milk out of the breast is an important tool. There's some great videos on YouTube on how to actually do this. This is just a quick example. It's really a press back and compress. And here's another picture, pressing back and compressing, or press back and compress. And then you can remove the milk from the breast and either use a syringe or put it in a cup. A lot of people choose not to use an electric breast pump, and once they learn how to hand express, they are very comfortable with that method and very fast and efficient with that method. And we can use alternative feeding methods, feeding ways of giving this milk to the baby. Here's a teaspoon. This baby is sitting up, and you can turn the spoon sideways and they will just kind of lap it up off that spoon. And here's a cup where, again, we sit the baby upright and we can tip that cup up and they will just kind of lick the milk out of the cup. So we don't have to use an artificial nipple. And these are temporary methods of getting the milk into the baby in a way that you can see it and the parent can see it, and we can help them get over that transition period if they're having a difficult time latching. Hale's medication and mother's milk is like the textbook for all medication research that's been done. And so if you want to know if a medication or an herb or something that the mom is taking is compatible with breastfeeding, this is the resource we would use. They have an online website. Most lactation consultants own this book and can look things up. And then they will give you levels of research and levels of compatibility. It goes from L1 to L5. And then using shared decision making, the mom can decide if she wants to continue breastfeeding or if she wants to continue taking that medication or not. And then this is just a picture of a double pump setup that as nurses, we need to be familiar with how pumps work. And it doesn't matter what unit you work in, because you will have breastfeeding, lactating women in all units, ER, med surg, ICU, surgery. You will see them everywhere. So we need to know just the basic functions of pumps. And there are plenty of great videos on YouTube on how they work. If she has inflammation or swelling, engorgement of that breast, we want to use ice packs or cabbage to help relieve that engorgement. And again, this is just a feeding log, keeping track of how often she's fed. And we want to see 8 to 10 feedings in 24 hours with 6 to 8 wet diapers in 24 hours after that first week of age or so. And this is giving her something like this to keep track of it, or using one of the apps to keep track of it is a good idea, because they're sleep deprived and parenting is difficult in those first few weeks. And then if our parents are choosing to bottle feed, whether they have formula or breast milk in those bottles, they need to know proper equipment, how the proper water to use if they're mixing formula. We also want that on-face bonding time, so holding that baby skin to skin while bottle feeding is very important. And then a brief introduction of when they're going to weed and introduction of solid foods. And the American Academy of Pediatrics recommends nothing but breast milk for the first 6 months. So there's no reason to do some of those recommendations that you get from your grandmas and aunties about putting cereal in a bottle or giving solid foods before that time. Really, it's 6 months. Either breast milk or formula is all they need. All the different discharge preparation needs to start happening as soon as that baby is born. There's lots of information we need to provide them with. Again, giving them something in writing, having access to some videos or something visual is a great way to educate them. And then sticking to the basics. What do they really need to know? Warning signs and symptoms, and when are you going to come back? Those are the most important parts of your discharge prep. Recognizing what is a normal cord progression, it's going to be clamped, and most likely this clamp will be removed before they leave the facility, and then it's going to dry and slowly get drier until it falls off. We don't want to immerse this in a bathtub or into water because that will decrease its drying time. It's not necessary to do anything to the cord other than fold that diaper down underneath it and not cause any friction. We're looking for signs and symptoms of infection or excessive bleeding. Knowing how to use a bulb syringe, super important for our parents. They should take this one home from the hospital, and it can help them if they see that the baby's having a hard time clearing the airway. It could save them from a 911 call. So squeeze it, put it in the side of the mouth, suck out whatever's there, squeeze it again, put it in the other side of the mouth, suck out whatever's there. And then if the baby's still unable to clear the airway, that would be at the point when they would get 911 initiated and on their way, and they could keep trying the bulb syringe. It can also go right into the nose and help to clear out any fluid there. A safe sleep environment versus what you see in a baby catalog. Looking at our sudden infant death SIDS prevention, we know that babies don't need bumpers, they don't need anything hanging overhead, they don't need blankets, they just need to be in a sleeping something like a sleep sack or something that will help them stay warm enough but not too warm. And they do recommend that babies sleep in the same room as their parents for the first few months. Again, here's all the different teaching topics that we're going to cover before they go home. Here are our warning signs. A fever of 100.4 or more or under 97. Remember that low temp can be a sign of infection. Central cyanosis, respiratory difficulties, difficult to wake, poor tone, will not feed, persistent vomiting, and not enough wet diapers or stool. And once again, these sweet little babies, these are my favorite to show you as we round out our discussion about the normal newborn. Where you get the little miniature guitar for these pictures, I don't know. And my favorite angry baby, who is probably in high school now. Okay, thanks for listening.